Thank you, Lynn. Now,
Yes.
green button.
I think the green one is the one to go with. If not,
We're doing well so far. The green button's not working. Do I press the red button? Can I press the red button? There we go.
excellent.
Look, this presentation will be a bit of a whirlwind update for mental health. The key focus is really on people who are more severely impacted by mental illness, and typically they would be clients or former clients of state mental health systems. I'll try not to use jargon, but I've been in this sector a bit too long to keep any firm promises. I'll cover 4 topics which seem a bit eclectic, but I was trying to talk about things that won't be covered by other speakers, but I thought needed to be covered. So I'll cover the National Mental Health Commission review and a little bit about implementation. I'll talk about lived experience, and it was really pleasing to hear the new South Australian Mental Health Commissioner talk about how important that is. That is a key issue for us in mental health. I'll talk a little bit about the National Disability Insurance Scheme, particularly around transition issues or risks that we see. And finally, I'll give a perspective on unmet demand by service type and what it means for a modern, balanced mental health and disability system. The National Mental Health Commission review of mental health programs and services in 2014 was a landmark report. And I understand that David Butt is here today or will be here later. I'm hoping there will be, because I will only scratch the surface of the report. It was a big one. It had 4 volumes and a summary. It covered a lot of ground. So I'll make a couple of observations, but if David Butt's here and you want to ask more questions, hopefully you'll be able to catch him in a break. The report needs to be read in the context of previous good work of the National Mental Health Commission regarding a concept that we call in mental health contributing life. The contributing life concept was developed through extensive discussion with people who have experience of mental illness. Essentially, it's a way of defining recovery, particularly from severe mental illness, in terms of building a good quality of life in the community. So it includes things like high quality relationships, appropriate housing, income, good physical health, something meaningful to do with the bulk of your time. This might sound pretty obvious to many in this audience, but in the mental health field, there are many who would be happier to draw a more narrow line in terms of the definition of what our job is in mental health, particularly for people more severely impacted by mental illness. The concept of contributing life as defined by people with experience of mental illness was central to the National Mental Health Commission review findings and their recommendations. The review proposed using the elements of contributing life as the basis of outcomes, of an outcomes-focused system, and noting, for example, that people were being discharged from hospital and treatment services into homelessness. So it's actually of extreme importance having that concept of what we're aiming for in mental health front and centre. A key finding of the review was to identify that we're spending almost all of our resources on high-cost services like acute and emergency hospital beds, the justice system and disability support. Essentially, that spending indicating that we've failed to prevent avoidable complications in people's lives. So it parallels very closely with Debbie's analysis of overall government spending as well. A key recommendation from the report was that over time, $1 billion needs to be transferred from failure end services to services that assist people to rebuild their lives in the community. Unfortunately, this was seen as taking cash from hospitals and was quickly rejected as unpalatable, even though the Commission was instructed in doing the report to make recommendations within the current funding envelope. I think it's an example of how relationships between jurisdictions can go significantly astray, particularly in Australia, with our federated structure. The review also recommended that primary health networks be the primary vehicle for achieving mental health reform from a Commonwealth perspective. We have 2 PHNs in South Australia, it's a metropolitan one and a country one. In terms of how it's all going, it's way too early to assess the success of these organisations. But as I'll get on to when I talk about the transition to full implementation of the National Disability Insurance Scheme, there are likely to be major gaps opening up as community support programs are cashed out to pay for the NDIS. In addition, at this stage, the Commonwealth Department of Health appears to be giving clear guidance that a more narrow version of mental health services is what they're after, and that means that they've put things like psychosocial rehabilitation in the community out of scope. This means that through current reform processes coming from the Department of Health, it's unlikely to address any gaps that arise with the transition to NDIS. The 5th National Mental Health Plan, you may have heard of it. It's being developed. Incidentally, we used to not be able to call it that. We used to have to call it the successor to the 4th National Mental Health Plan. But now we've got as far as calling it the 5th National Mental Health Plan. Initially, there was a broader consultation process in its development, but that's been abandoned, and now the drafting is much more tightly held by the Commonwealth. It's really not clear where it's going to land, but I guess I do hold some fears that it won't have such a strong focus as recommended in the review on contributing life type outcomes for the system. And also, I think in that respect, it may well fail to deliver what people with lived experience have advocated for many years. The National Mental Health Commission review talked about an enhanced role for lived experience workers in mental health. In mental health, one definition is a person who's employed in a role that requires them to identify as being or having been a mental health consumer or carer. Becomes an essential criterion of job descriptions, but job titles and related tasks can vary. Where does it fit in mental health reform? That's an excellent question, and I think we've got a lot of answers still to find. But in the words of one lived experience worker, Bridie, I think we will transform the system as we develop our own way of doing things and our own ways of opening up space for our distress and experiences to be understood in multiple ways, in ways that are actually through our experiences. The Mental Health Coalition of South Australia has some funding to do a lived experience workforce project. The key deliverables are developing standards and guidelines to support the non-government sector to recruit and support their lived experience workforce, and to create a workforce development plan for people with lived experience in the non-government sector, and to facilitate training and development, which includes the relevant minimum qualification of a Cert 4 in peer work and advocating for that to be on the subsidised qualification list. The NDIS, the National Disability Insurance Scheme, represents a powerful opportunity for the lived experience workforce. Whilst the NDIS does not specifically categorise peer work or lived experience support, there's no reason that services can't be provided by lived experience workers, especially if that's what a consumer wants. In the greater mental health system, there are many benefits from growing a lived experience workforce. A commonly identified benefit is how lived experience workers can provide a role model regarding how to balance their lives, and this requires a high level of self-knowledge, and another highly valued ingredient is a high degree of compassion. These are powerful tools for lived experience workers to assist others to transform their lives. So, moving on to the National Disability Insurance Scheme, there's no question that this will be a good thing for people who get access to it. I think it's fair to characterise that that disability support was a thing that the mental health and disability systems were doing poorly previously, and particularly as traditionally there's been poor access and resourcing for people with severe mental illness. That's notwithstanding some very good examples of good practice. So let me be really clear before I talk about issues, problems and risks, that NDIS should be a good thing for people who are significantly disabled by their mental illness. There'll also be a number of teething problems associated with implementing anything of this magnitude, and so I won't dwell on those. We're working hard in other places with the agency charged with introducing it to look at those issues. But a key problem is how governments will pay for it. And that's a very interesting question that's been answered differently in different jurisdictions. So in some jurisdictions we've seen that this has been by cashing out highly effective programs that have been carefully designed to meet the needs of people with severe and complex issues. We're still a year away, at least in South Australia, from the commencement of the psychosocial disability supports for adults in South Australia, but most other jurisdictions are much more advanced. Our organisation wanted to find out more about what's at stake, so we did a survey of the non-government sector regarding current services, who's using them, and some of the likely impacts of the NDIS. Of the 11 organisations that responded, we found just under 7,000 participants across 15 programs. That's including both Commonwealth and state-funded ones. We found that about 1,570 people, or 22% of participants, were identified as potentially eligible for NDIS, and nearly 5,500 identified as unlikely to be eligible. Breaking it down across funders, in state-funded programs, we found that less percent were likely to be eligible, and over Commonwealth programs it looked like a higher percentage, though within state-funded programs it varied considerably depending on what the programs were, from near to 100% to as low as about 4%. We broke it down program by program, and I won't go through them all, but for this purpose I'll just talk a little bit about the Housing and Support Program. This program combines housing and support in a flexible model where the support decreases as the consumer builds skills, hopefully on the way to building a better life or more contributing life. The increased capacity in the program goes to another client in need. The program can deliver a high level of support. So far though, we have no clear plan about how or if this program will transition in full or in part to the NDIS scheme. I guess there are some general comments and questions from our survey. So some of the Commonwealth programs earmarked to disappear had groundbreaking, for mental health at least, features, such as the Partners in Recovery program, which had a high degree of flexibility and assertive engagement. Some work interstate suggests that over 60% of clients in the program were actually hard to engage initially, and they expect that only about 50% will end up accessing NDIS. And we know from the pilots in other states it takes about 20 hours of support on average to get someone into the NDIS. So this is a problem for a tranche of people, including those on Partners in Recovery programs, about people who are hard to engage in existing programs and may well be hard to engage in the NDIS. Another thing that's happening around the transition is that some programs are already being changed in scope. So we've seen reduced numbers in some programs and a change in entry criteria towards people who are more likely to be eligible for the NDIS happening already in some programs. I think the impact of this is we'll see more unplanned admissions and crisis demand from people who can't manage in the community. And I think it's also really important to note that there was a view that prior to the introduction, prior to NDIS, that there was still a need to develop more step-up and step-down options in the community. And we've also seen a decline in some of those services in both state and Commonwealth systems. In general terms around these programs, I think relative to homelessness, some of the programs like Housing and Support Program, there was already significant issues around sourcing enough stock to move the support to more people. there's a great report that was done in Australia called, I think it's called Australians Living with Psychotic Illness. It's not a fun read, but it was a survey of about 8,000 people. And what it showed, amongst other things, is that people with psychotic illness were 10 times more likely to be homeless than the general population, and that half the people in the survey were on the public housing wait list. Another issue about these services in the mental health space is the preventative work that help people to build skills to maintain tenancies, but also having the relationships to recognise when people might be at risk of losing their tenancy. And I guess in terms of where we need to go already, it's to continue to improve the crossovers between mental health and housing and homelessness supports. To move on to my final topic, unmet demand by service type. In a media-driven world, you could be forgiven for thinking that mental health problems will be solved by more mental health beds. The Western Australian Commission had a closer look at this, and it's really interesting. A key fact is that mental health is funded overall relative to its illness burden. The disease burden related to mental illness is around 13% of the total disease burden, yet mental health is funded nationally across jurisdictions at more like 6 to 8% of health budgets. So, despite being almost on our 5th National Mental Health Plan, we haven't gained and maintained ground in this important respect. So when the WA Commission divided services up into 4 categories, ranging from hospital beds to community support, it looked at unmet demand for those services. And what they found was that all areas were underfunded and had unmet demand. But as you move from hospital to community support, the unmet demand increases from around 25% in hospital services to 3 times that in community support services. And so back to the National Mental Health Commission review recommendations, it's clear that they're spot on in terms of what they were advocating about moving from crisis end services to balancing more investment in support in the community, but we're not doing it. And really this is despite study after study and evaluation after evaluation that show that people with major mental illness can reduce their use of hospital services with the right supports and build a better life in the community. So in the 10-year plan in WA by the WA Mental Health Commission, a key feature is evening out the imbalance in the gap in unmet demand across different service types. So finally, regarding NDIS, some jurisdictions are starting to realise that they've made a serious error of judgment regarding how the NDIS will operate, and that cashing out highly effective community programs will compromise the effectiveness of their mental health system. Some have started to re-articulate the key elements of an effective mental health and disability system. So if you talk to Victorians, they identify the need for a balance of clinical treatment, community-based rehabilitation and disability support as fundamental building blocks of a good system. There's a quote in the National Mental Health Commission review from a consumer. They said, "I just want to emphasise that people with mental health issues are a part of the community and that our lives matter. Not only that, but by denying people like me the chance to have a stable life with stable housing and a reduction in poverty-related stress, you're also denying our kids and loved ones relief from those stresses." So we don't know where this is going to go in South Australia. We have a new commissioner, Chris Burns, and it's great to have him on deck. It was really great to hear what he had to say, and I know he's busy going out and talking to stakeholders across the state. His job's to create the next 5-year plan in South Australia, and we trust it'll be a good one. Thank you, everyone, and look forward to the rest of the day.